So welcome to the Duke Global Health Law and Policy Symposium. We're going to be talking about global health governance, specifically focusing on the mechanisms that can be used to keep countries accountable in a human rights context, and discussing and learning from the recent Ebola crisis. So our basic agenda for the day is going to be our 45-minute keynote speech. It'll be 30 minutes of speech plus 15 minutes for questions, but we hope that you all will participate. We really want this to be interactive, so ask questions throughout. We will have someone with a microphone in case you're sitting in the back and we can't hear you, and he'll come around and pass you the microphone. So please feel free to participate throughout. And if you're one of our panelists, we have seats in the front set out for you. Then we'll have a quick break, and it'll be really 5 minutes. It's just so that you're not sitting here for an hour and a half. And then another 45 minutes where we have a panel on lessons from Ebola. It'll, again, be 30 minutes structured moderator-led questions, and then 15 minutes for audience questions. But again, please ask questions as you come up with them. We'll break for 30 minutes for lunch, and then our second 45-minute panel, same structure, but on human rights in global health governance. So then we also have a meet and greet this evening at 6 p.m. at Satisfaction in downtown Durham. It is a sports bar. It's very casual, so we just wanted it to be an informal way for everyone to get to know each other, both to ask questions of our panelists who are attending or other attendees of this symposium, since this is plenty of people who share your interests. So welcome. Now that all the logistics are done, we'll get started. Our keynote speaker is Professor Benjamin Mason Meier of that other school. He's from UNC. He works as a professor of global health policy, and he's written and spoken extensively on human rights, both providing theoretical analyses of current policy and proposing frameworks for implementing policies that improve the country's accountability and effectiveness in upholding those rights. So we're very lucky to have him here today. And on a personal note, this was our first annual Global Health Symposium, and we hit some snags along the way, and he's really been helping us pull through them and make this possible. So thank you, Professor Meier.
Thank you so much. My students say that I'm playing an away game today, so I appreciate the opposing fans not booing when I first get up here. And
are ready.
it's going to be a long day. And so with the human right to health codifying our legal norms for global health, we need to understand the national policy efforts, I'll argue, to implement these legal norms for accountability and the mechanisms of accountability that are necessary for human rights realization. Good morning. I'm Benjamin Meier. I'm an associate professor of global health policy at that other school. And this presentation is really going to help kick off our symposium by discussing human rights accountability for global health advancement, with the human right to health proving increasingly relevant to global health governance, driven by a recent rise of global health initiatives, legal and policy commitments, and unprecedented levels of financial support in global health. Let me begin the day by arguing that there's a research imperative to analyze the impact of these rights-based norms for global health, bringing together several of the research policies and products that we've developed over the last 5 years or so, first at Columbia, then at Georgetown, and now at the University of North Carolina at Chapel Hill. I hope to discuss some of the varied mechanisms that are available to assess human rights implementation, to facilitate human rights accountability in global health, and to make human rights a reality throughout the world. This project really fits into my larger interest, as Danny mentioned, as the principal subject of my research is human rights under international law as a basis for public health. And so in thinking about how this fits within that larger framework, through some of my interdisciplinary human rights work at the intersection of international law, public policy, and global health, I study the frameworks that are necessary in both national and global policy, focusing on the development, the evolution, the implementation of human rights and health governance. But most of my work is theory-driven, because I'm an academic and that's what we do. But I want to talk a bit today about empirical studies and to think about an empirical foundation for human rights analysis in global health. I hope that this overview helps to frame some of the conversations that are going to take place following this, really demonstrating how we can develop an interdisciplinary empirical research foundation and how this can contribute to health and human rights implementation. So thank you to Danny, Ali, Kevin, for invitation to this insightful symposium. It has been a little bit bumpy and rocky along the way of developing it, but I'm excited to see people here. And I hope this presentation proves relevant to the studies of the students here, and it helps to catalyze some of the conversations that are going to follow in the panels that come. And so in thinking about this issue, I want to frame my remarks around 3 different areas of focusing on an empirical foundation for human rights by looking first at the development of human rights law for global health, reviewing some of my historical research, and describing the evolution of human rights under international law under a human right to health. From this understanding of the development of human rights law, I want to focus secondly on what comes next, the implementation of international law at the national level. Some states implement international law completely. Most, however, do not. So how do we know which governments are realizing human rights and which are not? The international human rights system has no way of really assessing this. We have no global judiciary. We have no global police force. We have no universal means of assuring realization for global health. So I want to end the discussion by focusing on accountability, because I kind of need this in my life right now. It's been a really difficult week of teaching. UNC is ranked #1 preseason for basketball. We have our homecoming football game this weekend, and we are playing the evil empire down the street. Why do I teach these students when they'd rather be focusing on sports? Rather than leaving academia and becoming a real lawyer like my mother always wanted, I need a reason to believe that academic research does some good in this world. So I want to end by analyzing the academic research that's necessary to study accountability, reviewing our recent global health policy research to study mechanisms for accountability through international treaty bodies, national policy reforms, judicial challenges, and civil society advocacy. And I hope through the application of this research, I want to end by discussing and hopefully framing the conversations that follow how human rights accountability can serve global health, how we can, through academic research, facilitate this accountability for human rights realization, hopefully framing a research agenda in comparative legal analysis in the years to come, to give me a reason to believe that I should stay a professor. But before focusing on my future and the immediate future of our panelists throughout the day, I want to go into the past and really begin by focusing on the development of human rights for global health. And so in developing international law to codify a human right to health, we see how this right has developed dramatically since the end of the Second World War, the founding of the United Nations. And I want to use the next few slides to describe this dramatic evolution through international human rights treaties, declarations, focused on global health governance, both in the United Nations and the World Health Organization, and then finally a reinterpretation of the right to health in the 2000 General Comment 14 in the UN's Committee on Economic, Social, and Cultural Rights. My early research, beginning when I was a student and continuing well after that, chronicled the political dynamics of the evolution of a human right to health from the 1946 WHO Constitution to the present day. Beginning in this post-war vision of human rights in the 1946 WHO Constitution, I'd like to look at the policy dynamics of the right to health at 4 seminal moments in political history. focused on the expansive, aspirational language of the 1948 Universal Declaration of Human Rights, the weakened legal obligations of the 1966 International Covenant on Economic, Social, and Cultural Rights, the reclaimed public health standards of the 1978 Declaration of Alma Ata, which would be codified by the UN in General Comment 14 to address determinants of health as human rights. And so starting in the aftermath of the war, with the drafting of the Universal Declaration of Human Rights still underway, the rapid drafting and adoption of the Constitution of the World Health Organization here in New York would make it the first international treaty to define a unique human right to health. In support of an expansive vision of social welfare for public health, states established the World Health Organization as a means to realize rights-based global health governance. In structuring the mission of WHO under a right to health, its preamble looks toward the enjoyment of the highest attainable standard of health as one of the fundamental rights of every human being. For the first time, this has been said, defining health positively to include, magically, a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And so to implement this expansive vision of complete health, a vision in line with public health's contemporaneous focus on social medicine, the preamble would look to governments having a responsibility for the health of their peoples, which can be fulfilled only by the provision of both health and social measures. And so through these far-reaching legal principles, grounded in a human right to health, WHO's constitution encompassed the aspirations of WHO's mandate to build a healthier world out of the ashes of a world torn asunder by war. And yet coming out of this, on the heels of both the birth of the United Nations and the WHO Constitution, the UN would proclaim its Universal Declaration of Human Rights on December 10, 1948, enacting through it not an explicit right to health, but a right to a standard of living adequate for both health and well-being, laying out specific underlying determinants of health, including food, clothing, housing, and medical care, and necessary social services. In preparing this right to a standard of living adequate for health, there was widespread agreement that a human right to health included both the fulfillment of necessary medical care, but also a wide range of underlying determinants of health. While the resulting language was less focused than many had hoped, this expansive declaratory language would soon be elaborated by specific international legal obligations in the International Covenant on Economic, Social, and Cultural Rights. This hope for expansive international legal language, however, never came to fruition. Despite global affirmation of an expansive human right to health, the ideological divisions of the Cold War would weaken support for the development of a human right under international law. The right to health was seen as a basis for Soviet criticism of the United States during the Cold War, focused on inequalities in health in the United States. And there are inequalities in health in the United States. And so the United States came to advance a very limited view of a human right to health, seen as relevant only to freedom from government intrusion, abandoning this idea of complete health rather than the absence of disease or infirmity, enacting a compromise between the conflicting Cold War superpowers. The United States would codify economic and social rights in the 1966 International Covenant on Economic, Social, and Cultural Rights. This is the original draft of the right to health from the United Nations. And really, it's amazing what you can find when you go back and look in the UN archives. We'll just do that again, Mike. There we go. And so as we focus on this, thank you for your service to the UN for so long. And so as we seek to codify not an expansive view of health, but a more limited, highest attainable standard of health, by which governments would bear specific legal obligations largely around disease prevention, focused on a reduction of infant mortality, the improvement of environmental and industrial hygiene, largely being driven by the International Labor Organization, the prevention, treatment, of control of diseases, and then as a bit of a nod to the Soviet Union, the creation of conditions to assure medical services in the event of sickness. And so since this international covenant, what I've called in my research the nadir of expansiveness and human rights obligations, the human right to health has evolved in subsequent international instruments to influence global health through international treaties, regional instruments, and national laws and policies. And so, at the high point of this, with growing agreement that WHO had the constitutional authority, the normative legitimacy to elaborate international obligations for underlying determinants of health, WHO has sought to structure the codification of health norms, to memorialize multi-sectoral norms for what it would call primary health care through the 1978 Declaration of Alma-Ata. And so in this progressive realization, states and NGOs would come together in an unprecedented way. Here we see Ted Kennedy sitting with Director General Houghton Mahler of WHO in the Soviet Union in the midst of the Cold War to revive a rights-based approach to WHO's Health for All campaign, reaffirming the norms of the WHO Constitution. Article 1 of the resulting Declaration of Alma-Ata would seek to bring together the three norms that we discussed in the WHO Constitution. To begin by saying that health, which is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity, is a fundamental human right that requires the action of many other social and economic sectors, in addition to the health sector. Creating a model for primary health care as a means to realize underlying determinants of health, with 134 national governments declaring that these criteria to be human rights that would have priority over other economic goals. The Declaration of Alma-Ata presents a unifying framework to advance justice and global health. But while the development of this Declaration of Alma-Ata ushered in a new normative basis for global health discourse under international law, it would be over another 20 years before this public health interpretation would take root in the international human rights system. And so in 2000, this Committee on Economic, Social, and Cultural Rights, the UN treaty body authorized by states with drafting interpretations of economic and social rights, and monitoring state compliance, as we'll discuss, with the International Covenant on Economic, Social, and Cultural Rights, would take up these evolving issues in its 14th General Comment. And in doing so, it would reinterpret international law, reinterpret it to conform with the expansive obligations of the Declaration of Alma-Ata, to provide an authoritative reinterpretation of what the right to health should mean for national governments, with this committee viewing the medicalized conceptualization of a right to health as anachronistic in light of modern understandings of health disparities. General Comment 14 implicitly acknowledges a correlation between individual medical care and public health, finding access to both medical services and primary health care services as components of a right to health, and in facilitating accountability for both policy gaps and implementation gaps. The committee found in General Comment 14 that the right to health extends not only to timely and appropriate health care, but also to underlying determinants of health, specifically listing out access to safe and potable water, adequate sanitation, food, nutrition, housing, occupational and environmental conditions, and education and information specifically focused on sexual and reproductive health. These attributes of primary healthcare systems would be assessed based upon key normative attributes of what the human rights community has called the AAAQ framework. Attributes for availability, accessibility, acceptability, and quality. And pursuant to these obligations, governments would be held accountable with respect to both policy gaps and implementation gaps, de jure and de facto violations for the political scientists in the room, or the law on the books versus the law on the ground for the legal scholars in the room. We all call it something different. But in focusing on these implementation gaps, let me now turn to focus on the development of national policy to implement international law. And so transitioning from the development of international law to the implementation of that international law through national policy, where once the health and human rights community shunned research on human rights, the expansive development of an international legal system has led to an expanding array of analyses on the implementation of human rights for global health. By ratifying human rights treaties, we imagine that states will acknowledge their legal obligations. They will realize the rights of their peoples in public health practice. However, treaty ratification shows a rather weak association, if absolutely no correlation at all, with national practice. Ratifying a treaty does not magically make people healthier. And so how do we get around this idea? How do we assess what countries are doing? How do we view the ratification of an international human rights treaty as only the first step in the effective realization of rights? To realize rights, states need to implement those rights through their commitments under national policy, their actions in government programming, and the results that are seen in people's lives. The process is important. And there arises an accountability imperative, I'll argue, to understand this process of national implementation for these international human rights obligations. And so in moving from the ratification of treaties under international law to the realization of human rights in people's lives, I want to focus on human rights implementation as structured by the UN under a structure, process, outcome typology. Illustrative of causal pathways, identifying not simply whose rights are violated, but why those rights are violated. This framework for commitment, effort, result addresses the links between policy cause and social effect, assessing the processes by which rights are realized, and allowing us to understand the ways in which rights-based outcomes in people's lives are correlated with structures in government programming and, before that, obligations in law. And so the UN adopted this tripartite framework to focus states on the incremental implementation steps that are necessary, that could be taken to progressively realize human rights, recognizing that not all rights will be equally realized by all countries at all times. And so with the recognition and the realization of human rights dependent upon legal reforms, dependent upon resource allocations, a focus on outcome alone provides scant evidence of what states are doing to realize rights, creating an imperative to focus separately on national structures and processes. How do we create accountability for these national practices? We need to focus on both policy gaps and implementation gaps. How do we assess whether states are implementing structures and processes to progressively realize a human right to health to the maximum of their available resources? I asked my students, how do we assess whether countries are implementing rights? How do we assess whether policies are instrumental to realizing the right to health? My students, go Heels, recommended a word cloud. My students are really dumb sometimes. It looks pretty, but it doesn't tell us anything about the implementation of rights. I said that my students are dumb, but we weren't doing a whole lot better in the legal academy in analyzing documents. We were simply analyzing the words in these documents, counting up the number of words in a document to assess whether it was more robust or less robust. Doing word searches. Did reproductive rights come up? Yes or no? But counting words isn't that much better than a word cloud in understanding the qualitative shifts that are taking place in national policy. And so instead of linguistic analysis, whether a word cloud, a word count, or a word analysis, I want to focus on thematic analysis through the rest of this talk. Focusing on thematic analysis through a focus on analytic coding, capturing the informational content of national efforts to implement rights, rather than simply focusing on the words. Where this method is only really starting to be used in order to understand national policies, mostly because of the time and the individuals that are involved to do thematic analysis. It's not easy. But I hope that this research agenda presents a novel empirical approach to understanding the scope and content of human rights implementation, in framing human rights accountability, but in examining the evolving thematic content of national implementation. What human rights mechanisms can we study? Where do we get the data for this? While not exhaustive, I want to focus here on 4 different mechanisms. I want to focus on international treaty bodies, national laws, judicial challenges, and civil society advocacy. As these mechanisms evolve for the implementation of human rights, I want to argue that there arises an imperative to establish precedents for these rights, to develop best practices, what works in implementation and what doesn't. How can we harmonize the practices across nations that are conducive to the effective realization of human rights and health? Academic research can provide this, I hope, can make my mother proud. Beginning with a focus on human rights treaty bodies. These treaty bodies present an exciting new mechanism of accountability for human rights realization. I say new because while they've always existed, recent reforms are finally highlighting their potential and their effectiveness for the first time in facilitating human rights accountability. With each core human rights treaty having its own respective treaty body, and we've already discussed the International Covenant on Economic, Social, and Cultural Rights and its Committee on Economic, Social, and Cultural Rights. These international legal institutions monitor state reports on the implementation of rights. Every 5 years, states report to the United Nations on what they're doing. How do we assess these reports to alleviate what people call the enforcement problem in human rights, that there is no police force, there is no global judiciary? How do we use these treaty bodies, or the new Universal Periodic Reporting System through the UN, to influence states, to shame states, we would say, through perceptions of human rights implementation and compelling shifts in national practice? And so these treaty bodies monitor state implementation by reviewing state reports, engaging in constructive dialogue with national governments, and developing concluding observations that recognize state efforts to implement the treaty and note gaps in policy efforts to implement treaty law. With each periodic report building on the one before it, we form a virtuous cycle, with each cycle of reporting improving state implementation. And so to understand the substance of these reports, we're currently engaging in 3 different studies to examine the changing content of this human rights reporting system. We're first looking at what states are reporting under a human right to water and sanitation, looking at how that changes over time. Secondly, we're examining a human right to health and asking, what are treaty bodies doing? How are they responding? Is there a correlation between state reports and concluding observations and the subsequent state reports. And then finally, we've been contracted by the Center for Reproductive Rights to ask, what effect are they having on this process? They send in shadow letters for each of these countries, shadow reports to describe what's really happening in the countries after they report. Do these shadow letters have any effect? When I say that we're examining the evolving thematic content of these reports, though, what themes are we talking about? Fortunately, the international legal system provides an answer for this, delineating the normative attributes of human rights that we have put into code books. And this is the front page of our code book on a right to water and sanitation. We rely on the UN's official human rights standards through this deductive coding scheme. We shared this scheme with 5 experts on the human right to water and sanitation. And I say we now for the first time. This thematic analysis takes a village, and these are my students, working with the special rapporteur on the human right to water and sanitation here to validate our code book. And then following this, they read 167 state reports to the Committee on Economic, Social, and Cultural Rights over the last 15 years. They coded each paragraph of these reports using our Atlas TI qualitative data analysis software. They assessed each of these reports on the basis of the type of information that's presented by states. Is it based upon structure, process, or outcome? What is the normative content of the human rights based on this AAAQ framework? How do we think about cross-cutting human rights principles, the populations that are addressed, the context of the reference, whether that information is presented quantitatively or qualitatively? Meeting with me every week to go over this coding scheme and make sure that we're coding consistently. While there are limits to this type of research, both in identifying the themes that are in state reports and making sure that state reports reflect the actual situation on the ground, this type of empirical work really gets us started in thinking about how reporting and an understanding of that reporting across every country can provide us with generalizable findings on state implementation and on treaty monitoring, and can generate more specific hypotheses for future implementation processes. This is an exciting area of research for us. And while I don't normally plug my articles, I do want to let you know that we are publishing this study in about 3 weeks in the Duke Journal of International and Comparative Law. I am grateful for the student editors, some of whom are here, for their support throughout the publication process and for taking a chance on a law review article that had 26 graphs in it. I wouldn't have accepted it. You are better people than I am. And so moving from international treaty bodies, I said that I would discuss national reforms. And while I want to discuss our assessments that are going on of national policies, this is by no means a human rights assessment. But because we have an entire panel that's devoted to Ebola, I thought that I would discuss a complementary accountability project that we're developing with the U.S. Centers for Disease Control, FHI 360 here in the Research Triangle, Michele Forzley, who is going to be joining me on a panel later today, to focus on the ways in which we can develop national laws to improve global health security. The global health security agenda has become one of the prominent normative forces in global health over the last 18 months. And we need to consider the ways in which laws are going to be necessary to realize this success. Gaps in legal infrastructure have hampered national responses to recent national public health emergencies, including Ebola, MERS, and the SARS outbreak, making it difficult, as our panelists will tell us, to quarantine infected individuals, prescribe novel treatments, and coordinate responses across nations. And so these gaps in legal infrastructure seek to be filled by the Global Health Security Agenda, developed in 2014 following the global freakout of the Ebola epidemic. The US government has framed and helpfully categorized by color 11 action packages that seek to prevent, detect, and respond to global health security threats. We can code laws on the basis of these action packages. We can assess whether national governments are implementing the global health security agenda. Where many countries lack legislative authorities to control epidemics, we can assess the way in which law is critical both to build national systems and to accelerate progress to implement the global health security agenda. Much work lies ahead in building the technical capacity of systems to secure global health security. But the same coding tools can be developed to facilitate accountability. And so we finished developing a legal framework to help us collect and code both enabling legislation and laws specific to the action packages. Here we've specified the legal domains that are necessary in order to implement each of the action packages. And we, this is a picture of the three of us, hi Michele, have identified the scope, the types, and the elements of laws that are necessary in order to do each of the 11 things I showed you before. From this baseline assessment of what laws are necessary, we're developing an assessment tool that will allow us to code national public health laws, to see whether countries have laws that address each aspect of each domain, of each action package for global health security, and using Law Atlas as a coding program to identify where national laws match up with our global standard. We're just shifting now, and we'll be doing so in the coming weeks, to specifically assess the laws in 25 different high-profile countries in CDC's opinion, coding these laws on the basis of the action packages and legal domains, analyzing the highest priority legal gaps for nations, and assessing what legal reforms are necessary to implement the global health security agenda. And yet, to assure that such laws are carried out on the ground, the law students will tell me that we need capacity for judicial challenges, that if you can't sue on the basis of it, what's the point, really? And so we need to return and focus on how we can code these judicial challenges. We've spent the last 5 years developing a database, returning us to human rights again, that can examine litigation on the basis of all these civil, cultural, economic, political, and social rights that underlie health. Where justiciability in economic and social rights is something kind of new. We need a means to help understand these resurgent social movements and how they're using litigation against recalcitrant government actors, spurred on by the rights-based response to HIV, beginning in freedom from discrimination and now transitioning to access to essential medicines. Litigation has produced many prominent public health policy reforms, has implemented rights in a way that is relevant to people's lives. This litigation has expanded dramatically since General Comment 14 and the elaboration of a human right to health. These cases are developing dramatically, especially in lower and middle income countries. And despite criticism that such litigation is distorting national governance, focusing us largely on access to medicines rather than on underlying determinants of health, there seems to be a clear trend toward more and more progressive cases. Yet in advancing this litigation to realize a rights-based approach to health, whether by individuals or by public interest law firms, we have absolutely no understanding at all of the legal strategies that are necessary for litigation success, the policy effects of that litigation across a wide range of countries, and the public health implications of these cases. And so we spent the past 5 years working with both the O'Neill Institute at Georgetown Law School and the Lawyers Collective in India to investigate this intersection of health and human rights in litigation, compiling, summarizing, and categorizing or coding health-related human rights in national courts. Here we see the front page of this database website, in which we've compiled all these cases that implicate health topics and specific human rights. We've coded this on the basis of various themes by which you can search for cases on the basis of the health issue that is implicated and the specific human right that is concerned. This is going to be extremely helpful in revolutionizing a litigation movement at the intersection of health and human rights. But the non-lawyers in the room will tell me that not all advocacy takes place in courts, even though this is sort of the tool that the lawyers have to provide accountability. This, however, is where things get tricky. How do we assess civil society advocacy? How do we look at other mechanisms of human rights implementation? We've begun asking this question by focusing on social media. And given the demographics of social media, this promises to be an exciting and expanding area of empirical research. There are over 1.15 billion users of Facebook every single day, over 500 million Twitter users, over 1 million unique monthly visitors to YouTube. Social media has not only penetrated the lives of the individuals in this room, and if you are on your phones now, I will assume that you are tweeting this lecture and not Facebooking your friends. But it's also become a foundation of human rights advocacy campaigns. How do we assess the effectiveness of this, given the near universal adoption of social media? It's generally seen as a positive opportunity for global human rights advancement in national policy contexts, raising public awareness of human rights issues by sharing information widely, free from editorializing, journalistic filtering, or government censorship. We see in the Bring Back Our Girls campaign that social media has allowed a local human rights issue to reach a global audience, to become a household name. This is having an influence on the traditional media, where stories that are trending on social media suddenly get picked up, usually about a week later. We get to hear about things like the insufferable Ice Bucket Challenge, the Movember campaign that I'm apparently not doing this year, the Coney 2012 campaign. How do we see these campaigns as bringing about policy reforms, disseminating policy ideas? Social media has lowered the barriers for participation in human rights at the intersection of global health. And yet, much like litigation, social media does not encompass the entirety of social media advocacy. If we look simply at the demographics of social media users, these social media advocates, or slacktivists as they are sometimes known, continue to be chiefly from wealthy nations, even when addressing issues of principal concern to those in other parts of the world. And we must question the efficacy of a tool driven by one group of individuals aimed at improving the lives of other groups of individuals, with no assessment at all of its effects. And so if social media is seen as a tool for advancing human rights and global health, for creating accountability for human rights realization in people's lives, we must survey not only the opportunities that are presented by these accountability tools, but also the limitations of these tools, including social media, to analyze the norms that are present. And we're beginning a study now to analyze the norms that are present in reproductive rights debates. We need human rights accountability mechanisms to make human rights real for people's lives. But we need empirical research in order to make sure that these accountability mechanisms are making rights a reality. And so facilitating accountability in health and human rights, with apologies for the fading quality of my PowerPoint artistry. We can look at these mechanisms as complementary ways of assessing national implementation. We can look at treaty monitoring, national law, judicial challenges, and civil society as complementary forms of accountability. But in looking both within and across these accountability mechanisms, we need to think about the policy actors that are driving this. We need to think about the health issues that are predominating in each area of accountability through human rights. And we need to think about the human rights norms that are predominating in each area. And so employing thematic analysis, such empirical research provides a way, a research base to identify transnational precedents, facilitating policy reforms across nations, enabling comparative analysis of human rights mechanisms, supporting legal and social scientific studies, and in framing empirical scholarship on the role of human rights as a determinant of the public's health, clarifying the impact of health-related rights on public health outcomes. And so this is, I hope, the beginning of a larger trajectory of research. An amazing time that we're in, with the development of human rights for health solidified under international law, with the implementation of human rights beginning at the national level, with accountability mechanisms springing up to make sure that nations are implementing human rights as they have ratified in their human rights treaties. But we need the tools to assess this government action. Academics can assess these tools. And I hope that we've provided a sense here of the types of academic research that are necessary to mainstream human rights in the practice of global health. Thank you again for this invitation. I look forward to your questions and our discussions throughout the day. Oh, are there any questions? I'm supposed to wait for the microphone to reach you.
So thank you so much for this presentation. It's wonderful. I have personally benefited from your database, so I'm really glad to know who has been working on that database with human rights decisions. And one question that you briefly mentioned is, what are the effects of these judicial decisions? I mean, from your knowledge in empirical research, what could be the effects of this judicial decision, especially in access to medicine, but also more broadly, on the problems of resource allocation? I mean, who gets to decide on these scarce resources in global health?
Oh, that's a really great question. And I think that the best answer to it is, I have no idea. And that's sort of the point. In thinking about these issues, we know that anecdotally, some countries have responded to litigation by expanding the pool of resources for access to medicines. Some countries have responded to this litigation by taking money away from public health systems in order to provide access to medicines for a subset of the population that has brought a lawsuit. In that case, it would seem that public health litigation is entrenching inequality, is furthering the divide between the haves and the have-nots, that we're focusing on a specific subset of the population with access to lawyers, bringing court cases, and taking money out of the health system for their particularized needs. There has been no complete transnational assessment. Our Global Health and Human Rights database provides the tools that are necessary to do a true comparative analysis. And I hope that people will take advantage of this tool in order to do comparative work. Because up until that point, all we have is select stories from select cases and select individuals and select countries. And we shouldn't be making global policy on the basis of anecdote.
along those lines. This is a very broad question, how does one make sure that the right to health isn't co-opted? In the case that she mentioned, a good example would be Brazil, where patient groups have filed lawsuits that have undermined the government's decisions and long-term strategy and their ability to negotiate. And in the case of Brazil, a lot of those patient groups have been funded by pharma. So I see the right to health as potentially going forward something that could serve the public, but also could provide a legal backstop for corporate interest in the health field. So just a question about how do we avoid the right to health getting co-opted, I guess.
And if I can return to the slide just before this, I think what we really need to do is we begin through our analysis to really understand what human rights research can do. Right now we have an example from Brazil, and this seems to be the prominent example, that in the Brazilian case, pharmaceutical companies are supporting this litigation in order to bring about access to their particularized drugs. This doesn't seem to be present in other countries, but we don't know the full extent of it. We don't know what the effects of these court cases are. We are not seeing any transnational precedent that's coming about because of this Brazilian example, so I'm not too worried about this spreading. There does seem to be recognition that this is happening in Brazil, and this is in some ways limited this from becoming a transnational movement. But I don't want to say that we should throw the baby out with the bathwater, that just because in some cases human rights litigation is used in order to support pharmaceutical companies, that means that human rights litigation is bad everywhere. And so the more we know about what types of claims are being made, whether those claims are successful, whether those types of claims are spreading, and what the public health implications of those cases are, we can't really say. And I worry, and I'm very familiar with the Brazilian work, and was the peer reviewer on that article. I support some of these national case studies, but what we need to do is not simply do what human rights lawyers have always done, which is tell a good story about one particular case. We need to become comparativists, to be able to look across contexts, to make generalizable statements about what works and what doesn't work, so that we can come up with solutions to prevent the harms that you're addressing while still facilitating the benefits that can be provided by litigation for human rights. Oh, okay. I think I need to...
Oh, actually,
Sorry.
I'm so sorry. We are 10 minutes behind the schedule already.
Never mind.
But we will have time to ask more questions. Professor Meier will return on one of our panels. But we're going to take a quick 2-minute break. And there's coffee outside, and I think it will be gone by the time lunch is here, so if you want that. And then we'll set up for our first panel.
Hi, good seeing you. Of course, if I have the picture, I'm going to put it up.
I don't know what I'm saying. But there's one thing that if we're going to do all this, I hope you will. Because when I tried to do all this, the AIDS stuff, I tried to go off stuff for I have no clue what a registration first means, or what the law means, or how you use it. So all the work done by lawyers like yourself, to make it relevant to how you make decisions about how programs work. It's never happened. And I tried for 5 years to implement John Mann's human rights framework, and I got nowhere. And I don't care how many lawsuits you take, I don't care how many times you go to the UN, okay, ministries of health, and that's where the power is, don't get it. They really don't, and they're even scared of the word rights.
Oh,
so we tried working with them by not using the word, because that word set us back, because it scared the hell out of them. It's just so I hope your research can look at this.
So we've just done 2 pieces of research on this that I'll just bring to your attention. The first is on PAHO and some of PAHO's work to mainstream human rights in its efforts, and it's done a really fabulous job
So
in
what
doing
made
this.
it work would be interesting.
So we focused on leadership from the top, from the director's office. We focused on capacity building, both at the stat level and at the national level.
Health ministries.
Within health ministries. And I mean, the Latin America Caribbean divide is a little bit difficult to talk about in short order, but a lot of programmatic work was done in each country in the region with national health ministries in order to understand what human rights could. So we just published this in the Journal of Law, Medicine and Ethics, and then we published, we're developing some work with WHO now to develop criteria that they can use to assess human rights mainstreaming in their work with national governments.
Because if you, I don't want to make that, but it really was the main barrier.
Yeah.
And I can't tell you how many times I've told law students if they don't understand the traditional health thing and the way policies get made in the health sector, it's impossible.
But part of what we can do with empirical research is to understand where human rights works and also where it doesn't. So when you know, you need another strategy.
Certainly, but you have these sectors, the law sector, the health sector, you're in a public health school.
Yeah.
But it's a real issue that people are becoming
Yeah, and
they get scared, but you don't know, you're afraid. So I'd love to see how this because that to me, because holding up the human rights journal, which John did all the time.
got no, yeah,
No way.
that I totally get.
So it just scared the hell out of me.
And we're starting to see.
Human rights struggle,
And is it going to cost me money?
Well, true, that too. But I think that it's an angle that I'm glad you're doing, because that research to me will make the biggest difference.
Yeah,
Okay, in
and-
terms of getting the health sector to understand how well can help them, and human rights can help them, and not. That's one of the shit.
One of the interesting things, and we wrote about this in Public Health last year, is that WHO has moved away from having a human rights office and having this sort of GER, this gender equity and rights mainstream.
That's an interesting idea. I don't know if it'll
And
work or
it's-
not work, I don't know.
But it's all based upon this idea that you have, that medical practitioners are scared off when they talk about rights. So to figure out where human rights can become a leverage point, use human rights, where equity is a leverage point, use equity, and where gender can get you there, use gender. And putting them all in the same office so that they can juggle these three.
Yeah, I'm fine. To get EMS to give up, to get the other to give up.
They're starting to do that now at Yale. I think Amy's had some success.
But what I'm saying is that I really think we could get lawyers, students, and somebody or even 6 months in a setting where they really have to deal with these issues.
And I think,
We can talk more about that.
I mean, we're starting to see more support from national ministries. We're starting to see more support from the higher levels of WHO. And Flavia has been really good at sort of pushing these issues to the forefront. Okay, yeah. And Larry,
I think we just got a
I'm
panel
on
full.
sabbatical next year, and Larry and I are developing 2 books, one on health and human rights, and then one on human rights and global health governance, which is going to look across institutions to ask whether, for example, the ILO approach to human rights, everyone will say it works better than WHO, but it's ILO. So it's a whole different thing. And I guess the question is, what institutional factors are driving mainstreaming of human rights in ILO that's different, or UNFPA or UNICEF? What does it mean to have a human rights mandate and to exercise that mandate?
How are you? Good to see you, sir. Good to see you.
I actually have.
Yeah, I certainly didn't take it when I was in law school.
I'm on one, so stuck to go back to the hospital.
So we're going to be talking about Ebola from the back.
Yes.
That's fine.
And we put them in the same room with public health people to develop a shared language.
Talk about some of our international efforts.
Well, we're trying it. Georgetown's developed a really interesting way of doing that with Hopkins.
Sulzhan is one of our students.
So, thanks, Mike. I look forward to the panel.
Was it a good conference?
Then you still go on outside of that. It's just
And they're being
Yeah, I guess I'm trying to do comparative work so that we can harmonize some of these processes.
All right, okay. What time do you want to end? Give me an end time. 12:15 sharp? Okay. No, I'll finish it. Fine. Okay.
But it's going, translating that policy point towards the implementation. You only get partway through and then the whole field's changed.
I will be, yeah. I have to leave eventually, but yeah. I'll be here for lunch, yeah. I'll try to be here. If it doesn't go over, I can stay.
See, it's these lawyers, you know, we can't.
So we're gonna pick things up now and we'll get going.
I've got all these notes and I've got literally 3 cards because I wasn't sure if I'd be standing.
Welcome back, folks. We're going to start our first panel. Some of it will be based on Professor Meier's speech, but really we'd like to focus on the panelists' specific knowledge and specialties. So to help us do that, we're honored to be joined by Dr. Michael Merson. He is the director of the Duke Global Health Institute. He's also vice chancellor of Duke and U.S. Affairs and vice president of Global Strategy Programs. He's had a distinguished career, to say the least. Starting at CDC, he moved on to WHO, where he was there for 2 decades. He became director of the Global AIDS Program, which was in charge of coordinating the global response to the HIV/AIDS pandemic. And then he became the first dean of public health at Yale before joining Duke. Along with this very impressive career, Dr. Merson has helped us with the Symposium from very early on, providing his wisdom with every step of the way. As a personal side note, when he was at the CDC, he took care of my people, tens of thousands of Vietnamese refugees, as they were moving on to a better life in the United States. So it's certainly an honor to welcome Dr. Merson, who will introduce the rest of the panels.
Thank you. Very kind, too. I forgot that story. Yeah, I forgot. The 300,000 refugees from Vietnam coming to Guam. And I was sent out there by CDC to screen them and send them to the U.S. And you're a great example of why that was a great opportunity and how much that contributed to this country. So, well, let me say first and foremost, welcome. And what I just said to Ben, and it's my first thought in being here today, is if only there was more health, global health in the law curriculum and more law in the global health curriculum, we would make great progress in this area. Because the more I've worked and had the opportunity to interact with the 2 sectors, the 2 areas, I realize the language is so different. And just the word rights scares the dickens out of most public health leaders. Just the word rights. And so it doesn't mean they should be scared, but they are scared. And we were just discussing some of the work he's doing, and I think we need more of these kind of interactions, but we need to get the students and faculty from both schools both the Global Health Institute and the law school more interactive on these issues so that we can come up even with a common language and a common approach to the kind of issues that you so beautifully laid out. So I just want to share that one impression. Easier said than done, but it is to me at the root of a lot of our challenge, that people work really hard, try to do the right thing, but do come with a different scope. Duke's very good at interdisciplinary work, but I think we have a long way to go with law and global health in bringing those two disciplines together. And I think your talk is a great example of why it's so valuable to do that. So switching to Ebola, and the panel, I'm simply going to introduce the topic with a couple of thoughts, and then ask our panel to share with us lessons that they think we've learned and not learned so far with regard to Ebola, bearing in mind the overall theme of our symposium today. So imagine a health problem in the most vulnerable part of the world, West Africa, with the most inadequate health systems, resulting in 28,000 infections and 15,000 deaths. And imagine that it's caused by a virus and that we know little about, causing a disease we know little about, with an immune response that we know little about. And imagine that people in that area assume that if they get infected, they're going to die because there's no effective treatment, and they have nowhere to go for medical care. So that's in a word, what happened with Ebola. And what happened as a result of that, to me, the most, in terms of the context of this symposium, I'll just say 4 words: incredible stigma, 4 thoughts: stigma, discrimination, fear, and panic. To me, that's what we saw. And what did that result in? Very bad policy and irrational responses. Even though the one thing we did know is that this disease was transmitted by bodily fluids, and that you didn't transmit it unless you were sick. That's pretty powerful data that we did have. And yet, despite that knowledge, clear knowledge, we wound up with irrational policies. What went wrong? We saw this before, and I fear we will see it again. And so that's what I'd love for our panel to be talking about and for you to be asking questions about in this short time that we have. I think that's all I'll say. Leave it to you to say the rest. We'll start with Chris Woods. Chris is a professor here in the medical school. He runs he's chief of infectious disease at our VA and chief epidemiologist there. But Chris is someone who probably is our most knowledgeable infectious disease specialist in the area of what we call emerging infections, new infections, but their diagnosis, their treatment, their prevention, and is really the best we have at Duke in this domain, particularly as it comes to low and middle income countries. So we'll have Chris go first and share a few thoughts. I'm going to be a little bit of a timekeeper here. We want to finish in 35 minutes, so nobody gets more than 5 minutes, and then they start to get in trouble.
All right, Mike's always good at giving me the hook, but it is nice to be here. Thank you for the invitation. It's wonderful to see. I've got a couple of my master's students. I run the Masters of Science in Global Health at the DGHI. And we've got a couple of students up in the audience, and 2 is a recent graduate. And on the panel, we have Sulzhan, who you'll hear from in a moment. So there are opportunities. We've actually had a number of persons in the program who are also law students. And so that's something I'd like to speak, going back to Mike's original point, where the interdisciplinary efforts can be encouraged further. I'll just speak a moment, and I'll try to highlight this theme that Mike mentioned of fear and irrational behavior. But much of the of that responsibility is ours who are participating in the response when we did and how we did. With regard to Duke's involvement, which is where I'm most knowledgeable, we initially didn't get engaged in the global situation. In fact, I was an early person when the questions came up of how or why or whether or not we should get involved and how would we respond in the international situation. I said, well, truth is this is probably just going to burn out like most of these other Ebola outbreaks have done. And this is in the spring of last year when I had persons asking if, oh, should I go over or not? I said, probably not, because of the timing of stuff. We'll expect this to go away. Of course, I was ignorant of just how important the issue of urbanization, of globalization, of just the post-war absence of infrastructure in West Africa impacted this outbreak in a unique way. And so there were a lot of unique things going on. I was proved wrong. Admit that. Come August, we were looking about how can we get engaged in a response. We're not a major service program. We don't have a large group of clinicians who are going to go over and set up an Ebola treatment unit, although we did have a number of individuals who were interested in doing that. There were issues that came up about how do you get people overseas to do that? How do we allow them to go? How do we get them back? What are the structures in place we have to provide safety for them and for the community when they get back? We ultimately did get engaged I'm very appreciative to my UNC colleagues who established a relationship with the Gates Foundation and a clinical research organization called CRM, Clinical Research Management. We put together a team of clinical researchers, and we actually implemented the very first clinical research trial using convalescent plasma in Monrovia, Liberia. These were coming on all at the very tail end of the outbreak by the time we got them started. That's another issue it would be good to discuss further. And then we set up some very unique designs to look at a number of different therapeutics that were becoming available. That experience informs kind of the rest of the contribution maybe I'll offer to the discussion over the course of the next half an hour. But the topics I would highlight would be, one, just the public health interventions, the issues of isolation and quarantine, those tools that the public health practitioner has to protect the public, how they're implemented on a local scale, on a global scale, the issue of travel restrictions and bans that play into that. At the extreme, there's martial law and curfews that were actually implemented, I think are worth discussion as well. The other topic that hopefully we'll get to touch on is access to care, issues of the fact that there were no medications, either therapeutics or vaccines, available at the initiation of the outbreak, the slowness with which we were able to implement the clinical trials that to evaluate those products as they did come online could have been made much quicker, and having an infrastructure that's based on the legal rights that were highlighted by Dr. Meier, I think is a great place to start in thinking proactively to make those types of studies move forward in a much more rapid way. It will make it better for everyone. The last point is stigmatization, as Mike mentioned. A major issue we're going to be facing is the survivor situation, particularly as we see a number of these persons start to relapse or have unusual clinical conditions. That is changing the paradigm of our understanding of the clinical spectrum of this disease and how that impacts all of our fear and our behavior related to it. So that's going to be another topic for us.
That's it? Any one lesson you learned?
I think establishing a plan of response that is broad-based and highly applicable across a number of emerging infections is a very useful approach, because next time it may well not be Ebola, it may be SARS or a derivative thereof. So.
Okay, good. Cameron Wolfe will say a few words next. He's also an ID doc.
he has the auspicious responsibility of directing the Duke Hospital biopreparedness planning. And I know Cameron has some very interesting thoughts about what happened. Cameron?
Thanks.
You'll hear his accent. He does live, though, in Durham.
Thanks. I'm very southern, as I described to my patients. Yeah, so I mean, I'm an ID physician primarily, but one of my haphazard roles, if you will, is to sort of be tapped on the shoulder if there's any sort of outbreak situations that may not only impact the hospital, but have a greater impact on the university or our interactions with the broader community. And I guess, Ebola was the quintessential example of where my life gets busy. So, I don't want to get into the medical detail, but one of the things we were sort of charged with was not only creating an internal response as to how the hospital and university would handle a patient or a potential patient, but then also how we handle our own the perception of Duke, how we handle the legal implications in some sense of what we're doing, and how that plays into sort of the national level of response. And so, I sort of penciled in 5 topics here that I think have some legal overlay, thinking of the overall theme. The first, Mike, gets back to what you were saying initially about fear and suspicion and how that ties to public health. In the midst of all of our efforts to respond last year, we had some, very public forays into the realm of quarantine domestically. And the one that, stood out for me was MSF nurse Casey Hickox, who, sort of arrived in the political foray of Chris Christie deciding to set up a tent outside of the New Jersey airport.
She had no symptoms, right?
Who was asymptomatic
Absolutely
at the time.
well.
And, that's clearly a response to the perception of risk rather than any response to real risk, although it was set up with perhaps good intention. But then the flip-flop that occurred there was fascinating to me, which is then that I think equally sadly she herself had no understanding of the perceived risk that she then gave to her community and was willfully sort of riding a bicycle around the sunny main streets with the media crowd following her. And I actually think in the end did maybe some public health disservice by her sort of open and somewhat flagrant opposition, if you will, to quarantine. Even following on from that, the sort of legal implications of then having, I think, one of the district courts overturning the state DHHS quarantine order, to me at least, may have been one of the first instances where a quarantine order was actually turned down. I think we've got a pretty good, rich, colourful history of quarantine orders being upheld in the United States, and so that was played out very publicly. And I noticed last month actually now suing New Jersey for their quarantine restrictions. So with that as one topic, the other interesting thing that played out for us very clearly is that even though you would think Ebola should be a national response, we're hamstrung to some extent in the United States by very different state rules in terms of how we can regulate issues such as Ebola. And, a couple of the things that played out for us was there's enormous difficulties in moving patients across state lines. There's enormous challenges in moving waste products across state lines. And so, we're a very nationalised health systems in some ways, and so it's even hard for our waste disposal truck to travel across the border to Virginia, let alone actually take a patient across to Virginia. Even when Nebraska, who are very well respected in the sort of fields of biopreparedness, were readying to receive a patient, the Nebraska airport, the quickest pathway for a patient to get from the airport to the hospital actually briefly cuts through Iowa, I believe. And the amount of diversion that the ambulance had to take it's just astonishing to try and overcome what would seemingly be a very straightforward legal issue, but was not surmountable in the heat of the moment.
Just crazy.
Just nonsense, but we'll get to that. Yeah, and then equally, even from our site issue at Duke, there's differences in the way that that states can enforce or suggest or nudge hospitals to respond. So, for example, in Virginia, hospitals were told, UVA, VCU, you will be the Ebola receiving centers, and you have to do it. And here, though, we run in a public health sphere at the state level, at least, that's very much, what's the word, decentralized. And so, they asked for volunteers. And so, Duke being Duke, didn't want to step back and let UNC take the forward. UNC doesn't want to be seen as the Ebola center, so they don't step forward. And so there's literally 3 or 4 big, very capable hospitals sort of sitting there playing jockey with each other. On a university level, the other thing that was, I think, interesting in retrospect is trying to balance the university's perceived risk against what is our mission. And so, this sort of speaks, Chris, I saw your challenges from the other side of the table, I guess, in some sense, because, the university would love to respond. We're a research institution. At the end of the day, we're a public health institution. It's appropriate for us to respond in a sphere like this, but you don't want your community to say, well, hang on, these guys are going to bring back an Ebola risk to Durham. That sounds terrible. How do you sort of grapple the perception of risk in that? In theory, should be easy, Mike, if you understand the biology of the illness, but I don't think that was in the public sphere of discourse at the time when we were trying to discuss that.
And to add to that, Cam, I was highly embarrassed that Harvard and Tulane and a number of other universities were sending doctor after doctor, healthcare worker after healthcare worker to Liberia, and here it was almost impossible. I was outright embarrassed that our university failed completely, almost completely, to respond to Ebola, except for the work that Chris did in West Africa, setting up the treatment unit. It was really embarrassing. So just to add to what Cam was saying, I would just point out how differently universities responded and dealt with the fear of Durham, the stigma of coming back and all that. It was fascinating to watch how the academic community, and there's a nice piece in the New England Journal of Medicine about this, about how varied the universities were. And we talked at the time, and I could get nowhere with the dean of the School of Medicine, nowhere on this, nowhere, or the head of the hospital.
Duke is very fear-averse in some aspects in this regard.
This was fear of liability, fear of PR and stigma, or both?
I think both.
Both. Fear of an inability to serve our responsibilities to the staff.
How embarrassing. How embarrassing. Larry Altman called me from the New York Times and said, "You people in the global health community, shame on you." And he wrote about it in a piece in the New York Times. And I told him he was right. He should write about it. That we couldn't come up with a way to respond in West Africa, to me, was a shame. So, but I don't want to keep that. I just want to emphasize Cam's point there is really important, how we looked as a university.
I would say, though, that it was across the academics in general were slow, and those who did respond had it pre-existing.
Yeah, they might have had a pre-existing relationship. Yeah, and it was easier, and they had a plan and had thought it through. We weren't the only one, by the way, that didn't respond. I want to say that we're reputed to be a leading global health university, and yet I think of the leading global health universities, it was particularly embarrassing.
Okay. And yet I would add the final comment that I think anyone who in the end applied to have Duke approval
the few that applied and got most of your work that you did with the treatment unit, I think that was great. I think that was the one exception they made quite quickly, Chris, or not?
Once we got a system in place, the approvals happened fairly quickly. I think it's more, we just don't have, we had a history of responding to the earthquake, and
many things, right?
We actually, Cameron had participated in that. And then the tsunami, we were a little delayed, and that's why I think we responded quite well to the Haiti earthquake situation. But in this situation, I think the fear did get the best of us, and I think it's actually on the actual clinicians being slow to demand the response from the university, because actually once we did and started to step up with a plan, ultimately I think they were responsive. So I take
No, you're not responsible, no. So our last speaker, we're going to shift a little bit. I don't want Chris to take all the and I asked how we say her name, and it's Susan with an L. So Sulzhan Bali is a student now in the master's program, but has PhD, interestingly enough, in molecular biology from the UK. and had the opportunity to work with the Nigerian private sector in Nigeria around Ebola, and is going to share what you learned. A very unique experience, I might say, that one of our students had. So please go ahead.
Thank you so much. I'm very grateful to Duke for letting me go. I can tell you it was not easy writing up a proposal saying that I want to go to Nigeria to study Ebola response. So I spent my summer in Nigeria. I conducted 56 in-depth interviews, 13 focus groups, and a survey looking at the impact of Ebola on private sector and also how private sector responded. I'd like to share some of the insights. And since we started with the topic of fear, let me just tell you something. When you talk about fear, when I spoke to the doctors who worked at the Ebola quarantine center, they told me even after a year, their medical peers refused to shake hands with them at conferences. Healthcare workers did not tell their husbands or wives, usually husbands, a lot of nurses I spoke to were female, that they were working at the quarantine center because they were afraid that the husbands were stigmatized. And that was the extent of fear. And all of this was surrounding the epicenter of the outbreak, which was the Index Hospital, where the Index patient and a Liberian American diplomat went. And that hospital coordinated with international authorities to contain the Ebola epidemic, yet suffered a lot of stigma. For example, fiancé of one of the infected doctors was sacked from her job. Another one of the doctors who was not infected from that hospital, her children were barred from coming to school because of pressure from other parents. That's the kind of stigma. That hospital, 90% of patients basically stopped coming to that hospital even after it was declared Ebola-free. It's been a year since Nigeria has been Ebola-free, and only 20 to 30% of the patients have managed to come back. So that's the level of stigma we're talking. So I feel the largest impact of Ebola was not direct. It was not the 28,000 infections or 11,000 deaths alone. It was much bigger than that, because of aversion behavior. A lot of times when there are novel infections, people make rational and irrational decisions to protect themselves at all costs. Now, that could be, stopping to eat pork. In the survey that I conducted, actually, 28% of people believed Ebola can spread by eating pork. And incidentally, when I asked them, what did you stop buying or their purchasing behavior, 65% had stopped buying pork. 73% had stopped buying kind of a kebab, like a beef or chicken kebab known as suya. And so the impact, there were high food prices, travel restrictions. And why that's important is because it affected two things. It impacted the Ebola response and it impacted the financial security. But this effect was much more amplified in the other three countries. So $1.6 billion lost in output and productivity in Sierra Leone, Liberia, and Guinea. $550 million in sub-Saharan Africa, according to World Bank. But this does not cover the informal sector. A lot of the GDP of these countries is dependent on the informal market. And these are the people who suffered job losses, high food prices, more expenditure. And that's why fear, so I have a term for this. I call it fearonomics. And fearonomics is basically when you have aversion behavior, when you have trade and travel restrictions from aversion behavior, not just from individuals, from countries. And obviously a loss of productivity. I've termed that fearonomics. So the impact of that is much more. So that was one of the lessons I learned. And the other lesson was how it affected the health systems. I just told you that how it affected the Index Hospital. Even other hospitals, people were afraid that if they go to hospitals, they will catch infections. So there was a 50% drop approximately in patients going to hospitals at that time. And the stigma that the Index Hospital suffered, it actually caused a very interesting phenomenon. A lot of other hospitals, doctors stopped seeing patients with fever. So if you had fever, basically they would not see you, they would not attend you, they would just turn you away to the Ebola quarantine center, the operation center. As a result, much more people died of malaria in Nigeria than they died of Ebola.
And that was across Africa. We saw a lot more malaria deaths.
But it was equally a domestic issue for us, is that the majority of people who turned up and were quarantined to do Ebola services have malaria. In the United States, they did not have Ebola.
Amazing.
I can count myself.
Typhoid or fevers or any number of things. I'm sorry.
No, it happened briefly with me as well when I came back. I was running high temperature.
She was quarantined.
Briefly, yes. I took a call from Dr. Woods and CDC. But so that's what was happening. The other thing in terms of law perspective I'd like to share is do no harm. This kind of coordination and accountability was actually, there was a lot of gap there. Financial accountability was not given. A lot of money was raised. A lot of money went very quickly, but not enough financial accountability or account of where the money is going was given. Nanosilver versus TKM7. When the first few patients in Nigeria became infected, they were offered TKM7. But incidentally, the Nigerian government at that time had gotten reports about nanosilver, which in some studies had been shown to be effective. But afterwards, it turned out that the FDA had not approved nanosilver, so they backtracked. So does that mean those patients were maybe not given treatment? Maybe they could have been saved? So that's something I think ethically one has to think about. In-kind support versus in cash. Again, like financial accountability. There's a lot of mistrust of the governments in a lot of countries, in fact. So that had a huge impact. Like, do you give money? A lot of private sector was afraid to give money to the government because they were afraid that it would not be used accountably. Last but not least, sustainable outbreak response was one of the lessons. And I felt that private sector can play a really major role in sustainable outbreak response. By resources, they can provide resources. Public money is often delayed. They can apply pressure for policy, sharing preparedness plan, pressure on government, logistics and procurement. That's like a really big issue in these areas, especially when areas in quarantine. Technology. So these are areas where private sector can really help, especially sectors such as aviation. Global coordination for managing public health emergency of international concern. From law perspective, I felt international health regulations is a soft law. Trade and travel restrictions were applied when, according to WHO IHR regulations, if you have travel restrictions without recommendation and trade restrictions, you need to give a scientific reasoning within 48 hours. And a lot of countries, a lot of developed countries defied that. There were 34 countries that had travel restrictions to the Ebola-affected region. In Sierra Leone, Guinea, and Liberia, all flights except Brussels Airlines stopped flying. But incidentally, that was not the case in Nigeria because it was too big a market, too big a hub to suspend operations. Nigeria recovered pretty quickly. So those were my thoughts.
Very good. So I want to congratulate you on introducing a new term. I hope the law school will teach a course on Pheronomics. It's a really interesting course. But so we can take this anywhere you like. I'd like the audience, remember the topic of the symposium is law and policy. And to me, it's an interesting question how much law helped us and how much policy helped us. But in this current situation, and how much better could we do it in the future. But I'm happy to take this any way we like. I could ask the panel first, but if we want to start in the audience, that's fine. Be provocative. I want you to ask and say provocative things. I want you to really say how you feel.
So I'm from the business school at the other university over here. And so I come from neither a law or health background. But we just heard from one speaker that, businesses can play a role here. And I'll just ask the whole panel, what role can businesses play? And maybe next year it'll be a business law and health panel.
So how can the business sector, how could the business sector in Africa gotten policy to be more rational and dealt with this terrible fear and stigma that led to the kind of things you described? Is there anything the business sector could have done?
Definitely.
Given a few examples.
So, first of all, in terms of policy, putting pressure on governments. Private sector holds a lot of power in terms of they have a lot of leverage on what policies are implied. Just to give you an example, at the Nigerian airport, after they discovered a bomb aboard a Delta flight, I believe, from Lagos to New York, they started doing manual checking. And at the time when the outbreak broke, aviation sector gathered and they said, we don't believe these people are changing their gloves. And we are afraid that even if you supply them enough gloves, they may not change it. We want you to start using an alternative. Because of that pressure, actually, what ended up happening was they started using metal detectors at the airport instead. Other instances is when aviation industry, they said, oh, we're not going to fly. We're kind of really afraid. A crew does not want to fly. And that puts pressure on governments and vice versa as well. And private sector business can play a really big role. The first of all being by just continuing business continuity, sharing their preparedness plans. By that, not all businesses have solid preparedness plans. Just by sharing that with the ones that don't, you can actually build a business continuity capacity. The other things could be, for example, technology. So there is, I got to know there is a technology called glass air. It's basically ethylene dioxide, which converts into vapor form and basically disinfects everything. And it kills viruses as well as bacteria. That technology was available. All the government had to do was communicate with the private sector that we need help. Did not happen. At least did not happen in Nigeria. So that's where contact tracing. Telecom companies can really help with the GIS method in contact tracing. That's something they can really help with. Recovery.
That's an interesting point.
So definitely a lot of, and coordinated response. The biggest oil and gas sector in Nigeria actually coordinated. So they had a focal point that was communicating with the government.
They did a very good job, because that's where the cases occurred.
Exactly. And they provided in kind. They said our expertise.
Port Harcourt.
Yeah,
and that's an oil hub, and that's why I think that's a really good point.
And similarly, Bridgestone's major tire manufacturing in, I'm going to say Sierra Leone, or Liberia.
They did a lot there.
And Firestone.
Huge Firestone.
So there is a lot the business community can do. It's a good question. Barak, you want to say, anyone else? Did you have your hand up?
Yeah, I think that, so you have a microphone? I think Sulzhan's observation that there's a big disconnect between reported law and actual behavior is something that not only is generalizable, but something that that lawyers have a lot of expertise about. And I can't imagine that Iowa was really on firm legal ground by keeping out.
Why? If their law says you can't do it, how do you?
And similarly, I find it hard. Let's put it this way. I think a very good lawyer would have found the same legal authority within HHS in North Carolina that they found in Virginia. So
that doesn't mean they want to have
the ability to, and frankly, I mean, this is being recorded. You go ahead. I think that I'll put this generically. University legal counsel are very risk averse.
Totally.
They're not always in full compliance with the only interpretation of the law.
You tell them that?
What?
Have you told them that?
I've had lots of discussions with them about that. Not on Ebola, but on other things. But institutionally, I understand where it's coming from. Pamela Brillard would be the first person to agree to say that too. So this is a way of saying that, with some intelligent familiarity with law and legal reasoning, we would be deeply empowering the kind of institutions that we have both in this country and in this university. So I say that with a fair amount of pride because I think I'm claiming too much credit, but to some degree, this conference was a product of global health students taking my class at the law school, and I think that just shows what kind of possibilities there are when you combine that interdisciplinary dialogue.
Okay.
Yes.
I'd like to add to that comment. I think that there's an unfortunate disconnect between the public health community and the legal community.
You mean at Duke or in general?
In the world, everywhere.
World.
At WHO, at the World Bank, at all the development agencies, in ministries of health around the world. You can go into, and I work in the ministries of health in developing countries, it's hard to find a lawyer. And if you find a lawyer, the lawyer is hooked to the hip of the minister, period, the end, and is not available to the actual implementing departments so that when an emergency shows up, nobody's thinking to ask the lawyer the question. I do IHR legislative implementation, and we insist that there is a public health person and a lawyer in the room at the same time. So now I have, let's say, the Emerald region of WHO, public health and lawyer from those countries. You put them in the room, they've never met each other. So what's going to happen when the hits the fan and everyone's freaking out and they don't think, oh, let me ask the lawyer. Moreover, people think lawyers just do litigation. They don't think lawyers do constructive development legal work, which in fact they do. But not many of us do it, and it's an area of practice that I would like to talk more about.
Can I ask a question? Do you think the average person, a lawyer in a ministry, would understand that what I said earlier, that this disease can only be transmitted if you're sick, it can only be transmitted through bodily fluid, and therefore that has a big impact on the way we might shape our policy? Do you think that most of the lawyers you meet in ministries would be able to move from that, say, simple fact to helping sound policy be made?
Of course,
or would they
could.
get into this litigation fear like we see at Duke?
Because litigation is something that's unique to the Western world. In a lot of developing countries, you don't see as much of this litigation because there isn't a huge private legal bar. So that lawyer is going to be part of a decision-making team. He or she, usually a he, is not going to be the only decider. The minister is going to make a decision. So you can have input into that decision. That doesn't mean that the law itself will carry the day. I wish it would many times, because it could certainly help a lot of things, but it isn't the only factor. And so you don't get great decisions sometimes in the heat of an emergency. But there's a more important role that the law can take and the lawyer can take, and that is to advise the ministry on the rights and authorities and powers and responsibilities in the case of an emergency while planning to be prepared for emergencies. And that is what IHR asks ministries and governments to do. But ministries and governments haven't completed that task. And I don't know how many more emergencies we need. I don't know how many more tsunamis we need, or Ebola outbreaks, or whatever, for us to get on the task that we have to do to be prepared for these things, never mind to do the day-to-day running of the Ministry of Health at all the other levels of work we have at hand.
Okay, thank you. Yes? We have a number of hands. Let's see if we can get to them, and we have only 5 minutes.
Just a quick comment before the question is, I think it's really important the point about the proactive nature of engaging the legal community, because what's not going to happen, or doesn't happen effectively at least, is engaging the community in the midst of the crisis, as you mentioned. And for one, as a public health professional, that's not the first place I'd be turning anyway, because you're worried about slowing things down and causing bigger problems.
You raised.
Exactly those reasons. So it
it's a
has
good
to
theme,
happen.
very good theme. That's why all of you in the room here are going to come out of this knowing what to do. Go ahead.
So there's a term, and I appreciate what you are all trying to do today, but there's a new book out on it, collaborative intelligence. And in a sense, that's what I believe this meeting is all about, is bringing different players together to address this. But I'm always interested in a number of the post-Ebola meetings that I've been to, that there is really never a mention of private industry and the other different players that formed the different alliances to move the vaccine candidates forward. And this is probably from my rather mixed and mostly private international law, biopharma law background. But our group has been discussing for over the last year with all the different players that were involved in forming these alliances and what their perspectives are on risk and sharing financial risk as opposed to liability risk. For instance, the PrEP Act took care of liability risk for clinical trials in the U.S., but it doesn't take care of risks outside. So the companies that were based in Europe had to form not only their own consortia of players, but a consortia of insurance companies that covered the liability risk. And so what we've been putting together, what we've been trying to put together are the commonalities. So where are the intersection points between the pharma companies and the funders and the different developers of these drugs or vaccines to try to figure out how we can better prepare the transactional part of developing the next response to emergency outbreaks.
We only go ahead.
My
We only have
question-
another. I want to get one more person. Yeah, go
I
ahead.
just had one question. One question was, do you think that we can achieve a common definition of an emergency infectious disease outbreak?
I'm going to pass on that.
Yeah, but I did want, I'll mention that the way industry did come together eventually, and both on the therapeutic side and the vaccine side, was very helpful. Still slow to implement. Much of the information was still caught up in the WHO infrastructure, which I would argue did facilitate things, but also ultimately didn't lead to a final implementation. We have an FDA workshop on Monday and Tuesday looking at actually establishing new clinical trial designs or establishing new clinical trial designs that can accept multiple entries from different companies to be tested concurrently. These are designs that will facilitate getting to an answer much more quickly. And one of the designs that we put together during the course of the outbreak is going to be presented at that meeting. But again, we had to have this communication. Ours was a therapeutic, not a vaccine study, so we had to get all of the various companies who were developing biologics or antivirals or just repurposing drugs and talking to their companies. And it became a real logistical.
Last comment?
Yeah. I think that whenever we see a collectively irrational response to a given situation, it's easy to ignore the extent that the individual actors are acting quite rationally, either because they're ignorant or because they're aware of the uncertainty. And I guess my question is, in this case, the premises on which those individual actors are acting and using their rational approach, have they changed at all, and maybe have they worsened?
I think a lot of the problem that you're identifying, and it was mentioned earlier by Ben about social media and about the media, I think the media did a miserable job, an absolutely miserable job of informing people about this disease. And I think that was at the root of a lot of why people acted the way they did. I listened to reports. I could not believe what the reporters were saying. I could not believe what was on social media. It's just outright irresponsible. But it's also because people react quickly. They don't have the facts. They hear a fact and they repeat the fact. And that gets it more, supposedly make it more true. And unfortunately, it isn't. And we mix up diseases between flu, which is transmitted before you're sick, with Ebola, which is transmitted only when you're sick. I mean, we get one is respiratory, one is bodily fluids, but media, we're asking the media to have a knowledge base that is tough. And I think a lot of our problem that we're not talking about here is how do we convey information to the public, which is, in this case, was just miserable. Look what happened at CDC with Tom Frieden. They actually took him off the media because CDC was doing such a poor job in the beginning. He was no longer doing the press interviews. Tom wasn't well briefed, or he's not good at it. I don't know. But they actually removed the CDC director as the leading spokesperson for Ebola. So even he had trouble. He certainly knew the facts. So I do think that the ultimate responsibility here is with public health communication and getting the right message out. Is really where the problem starts. I don't know about Nigeria so much, but I do know in this country, was it the same?
So I can actually
Just quickly give that.
Yeah, very quickly. You're right. There's no one size fits all when it comes to infections, and that is one of the biggest reasons these things happened. In Nigeria, we saw rumors such as salt, like drinking salty water will cure you of Ebola. You actually had as many deaths due to drinking salty water as Ebola in Nigeria. It showed 20 deaths. Holy water, one of the preachers, T.B. Joshua, he was actually saying he has holy water that can actually cure Ebola. He even sent 4,000 bottles to Sierra Leone. And the Nigerian government stepped in and saying, you can't continue this, otherwise you'll be in legal trouble. So yes,
Good.
You're absolutely right. Communication and making sure rumors don't spread is very important. But also social media can play a very important role in facilitating resource mobilization. And we saw that with Ebola Alert. And a center, which was social media, a Twitter campaign to tell people about the right information on Ebola, which incidentally CDC started following as well. So it was, yeah. And very quickly, taking the lady's question regarding your private sector, that is happening. Ebola private sector mobilization group EPSMG was a group that was created in Sierra Leone, Liberia, Guinea to continue talking between private sector. And in Nigeria, you have Private Sector Health Alliance of Nigeria, which is what partly also, they were my host organization. They're starting to talk about how pharmaceutical companies and other banks, oil and gas, how can they all come together for emergencies?
So thank you to the panel. We really have run out of time. We could go on, and it's a fascinating subject. I want to just ask one thing before we close to the students in the room. If I had offered you a ticket to go to Liberia at the height of the outbreak, but you weren't going to be working in the hospital or healthcare setting, to go as a lawyer to advise WHO in the office about what should be done in terms of the rights of people, how many of you would have gone? How many of you would have been afraid to go? Be honest with me. So you see,
Couple are doing both, which is
My
good.
wife would have.
I'm just pointing out, you are very knowledgeable people. You've just heard a long discussion on Ebola, and and yet very smart people. I would have absolutely no fear of going whatsoever, not in the slightest, to go to an Ebola-affected country in the middle of Ebola. Not now. Seeing a patient would be different. I'm talking about in a non-infected situation. But it just points out the challenge to your question. That's why I asked it. That we in this room, people have different fears and concerns that illustrate the challenge that we face. So I just wanted to finish with that because I hoped that we would get a mixed response, which we did. Thank you very much.
All right, so just like before, we are behind schedule, but we have lunch waiting outside. If you could try to be back in by 12:30, then we'll get started then. It's not a little late, it's okay.
You just tell her you're going to Nice job.
It is a.
Nice,
No,
you're
you were
fine.
marvelous. You were marvelous. I wanted to.
Okay, just trying. Yeah, no, it's really cool.